Next up is Dr. Peter Ree. Everybody knows Dr. Ree. Interesting, we just kind of reminisced a little bit last night. He started this along with Dr. Notrika and Dr. Chris Salvino, and we were just briefly talking about back in 2008 when they had kinematics here, and of course it was much smaller, and now the amazement how big it's grown. So it's my honor to have Dr. Ree back up on the stage talking about traumatic brain injury, how we can make a difference.
Thanks again for the privilege of joining you here. We'll talk about brain injury, I guess, and try to keep it short. So anyways, I'll talk in a few minutes about traumatic brain injury. What can we really do about it? Have we actually done anything for traumatic brain injury? I think that overall, I hate to say it, but I think what we've been able to do is not a lot. When you injure the brain or the spine, some of that is permanent, and as much as we have been able to do in medicine, sometimes it feels like it's a hopeless situation. But there's still things we can do around it. We can talk about things such as injury prevention. So I'm not going to be able to go through everything on traumatic brain injury in 20 minutes, but we have been able to publish about 45 publications in the last 60 months. So I'll focus on that because I know that body of literature a fair amount because I read some of my papers. But with injury prevention, I'm going to skip on some of those. Has anything changed in the management of this? So I'll skip on things a little bit in order to save us some time, such as coagulopathy. I know you guys love seeing coagulopathy stuff and all those things with enzymes and so on. But we'll talk really focusing on a couple of things: management of resources, so we can do things that makes a little more sense. And I'll give you one idea about potential therapy as well. In literature, when we talk about traumatic brain injury, there's also a head injury, like this guy here. Can you see if the video works on the right? But these are people who were shot in the head and not necessarily in the brain. Looks like maybe this one isn't working. But that video, if you can imagine, is a person with a bullet hole in his head just sitting up talking to you. Okay, so that goes into the category of being gunshot to the head versus actual brain matter, actual bullets hitting the brain itself. And, it's amazing that we can do crazy things to ourselves and survive this. This is a video as well. Can you hit this video? It's a great video. This guy, oh, here we go. This guy was really angry at the nurse, so he stabbed himself with a thermometer in the eye. So if you say put a pencil in my eye, this is what it kind of looks like.
So this is all the media.
Looks like, is it stopped there? Looks like it is. Anyways, what the video will show is how they do the craniotomy, and for people who haven't seen operations in the brain itself and then pulling out this thermometer, it's just an interesting case, and it looks like it's probably not going to play, so it's all right. Can you hit this one? Maybe this one will work. Let it go. So kind of archaic, we still drill through the bone to get down to the brain. I think some days we'll be able to go through it without actually cutting the bone off, but this isn't rocket science. Just brain surgery.
You're coming easy?
Mm-hmm. Yeah. Slow. Mm-hmm. Tip it out.
Okay, so anyways, traumatic brain injury. When I was in the military, all my textbooks said that 90% of all of these patients, 95% should go through surgery and have and undergo neurosurgery. And how many people here have seen people shot in the brain? And how many of them went to surgery? Right? Well, I didn't understand what the difference was, because in the United States, in civilian trauma, what they do is they let them die. So, especially if they come in with a low GCS, they think it's futile, and the survival rate is about 10%, and that's the national average. And we were able to change this very quickly in Tucson, and then when I took my job in Atlanta, we did the exact same thing. Their survival rate was about 10%, and the point is that we can change this, and Dr. DeBose, military surgeon, published that in the military, the surgery rate was much higher, and the survival rate was probably at least double of what civilian trauma rates were. And so we looked at this, and what we were able to do is change our survival rate from 10% to about 46%. And the surgery did increase a little bit, but how do we do this, and does this really matter? This is an ethical question in many ways, because as you remember, there was a congresswoman shot in Tucson, and we actually published that paper at the same year that Gabrielle Giffords was shot. And around the whole country, people who weren't in medicine were amazed that a person could be shot in the brain and survive, but this happens a fair amount. This video also plays, and this is a video of Gabby. Oh, go back and see if it'll play. This is a picture of Gabby actually riding the horse, on one of our horses, after about a year after her event. Nope, doesn't play. Okay, this one doesn't play either. Oh, it does.
Robert Carpenter. I've been with the City of Tucson since December 1st of 2000.
But a non-verified residential alarm call is generally something taken care of very quickly. However, that is a call I got shot on, so there you go.
I had that feeling, as every street cop does after a while, that someone was inside. As I was walking out from an unknown location, I was shot in the back of the head.
And they did lights and sirens. I knew that it was serious. They had told me that he had been shot in the head.
And underwent decompressive brain surgery. They removed part of my skull to allow what was left of my brain to swell. Basically, that much right there.
Lost the use of his left arm and some of his left side. It was very hard. It was very hard. It was very hard seeing your husband so drastically changed.
So, there are good survivors after this, and one of the problems is that there are people who don't come back to consciousness and activity as well. There are people that do remain in vegetative states, but there are so many people once given the chance in recovery and resuscitated that they will do well. So what is this aggressive resuscitation that changes the survival rate so much? One is euvolemia. That makes sense. I don't think I need to convince anybody. We're, again, very aggressive with blood and blood products. I use hypertonic saline, and that's going to be you can expand on it. I use 5% because they make and sell 5%. So if you can use hypertonic saline, 5% is a few points better than 3%. Vasopressin. T4 protocol, very aggressive with T4 protocol and vasopressin before they're declared brain dead. There are some people with traumatic brain injury after the declaration of brain death that you can use vasopressin and T4 to help stabilize them, but we'll start that immediately when the patient comes in with holes in the brain. And then really, you got to stay up all night, and you got to care. You got to really want to give this a shot, and because a lot of these people that with devastating intracranial injuries will die, but what this also does is it makes a big difference in organ donation. We started doing this over the years, and basically it just says that when you use this, including PCC, to stop their coagulopathy as they bleed out their brains, there's a lot of people that come in, if they're alive when they come in with holes in the brain, even though if the brain's irreversibly damaged and they're going to eventually die, the issue is, will they exsanguinate or not? And for the patients who exsanguinate right now, I don't have a good therapy for that because we can't go in and just put a tourniquet on their neck, and that doesn't work well. But if they don't and they clot off themselves and they herniate and die, those become very, young people who do that in this situation do become organ donors. So we were able to publish on a lot of these things showing that the aggressive use of T4 protocols blood transfusion, vasopressors makes a difference. And basically, all this points out to the same thing, that if you stay up all night with these people, and I actually learned this from LA County when I was working there. They used to have our fellows stand by the bedside, and their basic direction was if the patient dies, they die. But if they stay up with these patients all night long and really are aggressive with them, they do well. Donors in T4. Now, in this study that we published, what we showed was that although there were more people that survived, 46% of them, about half of them survive now, that means that the organ donor pool decreases. Okay, despite that, we were able to really increase the number of donors and the number of organ donations overall. As a matter of fact, in Grady, we haven't published this yet. There were at 20 organ donors per year for about 10 years straight, and in a matter of 2 years, we were able to get up to 60 per year. So organ donation, I think, is a valid end goal for this process, especially because the circumstances of the people who get gunshot to the brain, there are a lot of very young people that unfortunately get shot like this, and their organs are absolutely precious, and horrible to see them get wasted. Also, you have to also keep in mind that everything is taken with some judgment when we do this, because I remember one morning he came in and they were very aggressive with this person who clearly had a transcranial gunshot wound, and I was like, why did you resuscitate this guy? And they go, well, I thought that's what you wanted to do. And I said, yes, but he's 97 years old. So a little bit of judgment. Okay, not going to talk too much about guns, especially in Arizona when people are packing all the time. I'm not a gun freak. I'm not a gun hater or anything like that. There are issues, and I do show some of these things because prevention-wise, we published on all the gun issues as well, and gun safety for children. But we're going to try to take little baby steps as we make clinical change. So why is change so hard? Let's talk about not necessarily management of the injuries itself, but another way to really impact healthcare, which is management of resources. That black blood there that you see, that's an epidural hematoma. Those are the few individuals when you get a fractured skull and they're normal, the brain's okay, and they get a pressure that goes on in the brain that you go whisk them and get rid of that, and it really helps. But these are severe brain injuries, and then you just see some concussions, and now we're seeing all these little concussions. The incidence of traumatic brain injury is rapidly increasing in this country, and the question is why? So we've published on helmets. The helmets are useful to prevent scalp lacerations, but they're not that great. A piece of plastic with styrofoam underneath it, meaning not that you shouldn't wear helmets, but that we should probably design truly better helmets that's going to help brain injury as well. And here's an 18-year-old that fell from a ladder, GCS of 15. And so this person was flown into me for his traumatic brain injury because he had blood in the brain. And you guys can all see it, right? Well, the person who flew this person to me was angry that I was asking how big was the brain bleed, because it was an outlying hospital and they had a radiologist in Australia reading it and said that this person had an intracranial hemorrhage. And so the question was, how big was it? And they said, well, I don't know. I didn't look at it. I just read the report. And I said, well, how's the patient doing? And then they could see how aggravated they were getting at my questioning. I said, well, he's okay. And then my question was, well, why do you need to send him to us? Because he had intracranial bleed. So that was the automatic knee-jerk reaction to this. So if you scroll hardly enough, you can find a pixel of bleed somewhere. But traumatic brain injury is a clinical diagnosis, not a radiographic diagnosis. Okay, so when you lose consciousness, how long were you down? Because if I got someone who's really been training to hit your head as hard as he can in a precise fashion, and you fall down and become unconscious and you can't remember, if you get up in a few seconds, they'll let you keep fighting. Okay, and we don't scan these guys time and time again, right? We don't scan them every single time they go down. They have to go down for 10 seconds at least before we stop the fight. So how do you ask these guys, how long were you down? And so it got to a point where anybody with any, if do you remember anything? If you can't remember what you did yesterday, we're going to start scanning your head. So this is the reason why traumatic brain injury incidence has increased, because we have started to scan everybody. The only contraindication to head CT scan is the lack of a head. So, we just want to draw the line somewhere on this. And this is back in 2001 when we said if you come in with a mild head injury, GCS of 14 because, you got in a bar fight and got punched out and you don't remember, but you also happen to have taken 8 doses of beer, and that's why you aren't acting so normal. And you've seen these people in your ER, right? People with 8 doses of beer that aren't acting so normal. But in the morning, and you scan them, but in the morning, they're sobered up. And they're doing much better, and they want to go back to teaching the neurologic classes and things like that they do at the colleges. But we want to follow them up with a CT scan, and we don't follow our clinical status, and this is the problem. So we started showing paper after paper of this, saying that, you don't need to do things routinely if they are okay clinically. But sometimes if you radiographically look at them, even though they got better, they were drunk, but they're now awake and alert and ready to go back to work. But if you scan them, sometimes their head gets worse, okay? And then what do? You consult them, right? You consult the neurosurgeon, and they're busy enough as it is, and they don't make enough neurosurgeons so they can keep the salaries high. And these neurosurgeons, they hate you when you call them for these minor things. So repeat head CT scans, you don't need to do it on a routine basis. And so this is what we started to do with prospective studies and showing that you don't need to do this. Because interestingly enough, about half of the CT scans show no change. And then about 20% of all the 20 to 30% of CT scans show a progression or worsening, okay? And then 20% show improvement, which I don't understand how you can show improvement in 6 to 12 hours. So if I kicked you in your thigh and scanned your thigh, you'd see that hematoma and bruise. And that just means that in 6 hours, if you repeated the scan, half of them would be about the same. About a quarter, the remainder of it would be a little worse and a little better, okay? But this little worse, if you get a little worse, what do you do for it? If you get a contusion in your brain and it gets worse, what do you do for that? Radiation therapy until it stops, right? So what we're trying to say is put this in correlation with the patient. If the patient's not doing better, please scan them, by all means. But if they're doing okay, don't have to do it. And then it also depends on the GCS. If your GCS is less than 8, we have found an occasional person that we can't examine that get worse enough on the CT scan that we have to do some intervention. It's very rare, but it's there. So if it's less than 8, a routine person is okay. But in an examinable person, you can follow them clinically without just scanning them all the time. So can you also not call a neurosurgeon? Because there's only one thing that ticks off a neurosurgeon more than you calling them, and that's if you don't call them. So what we were able to do is publish and say, yes, the ER physicians and the trauma surgeons can manage the mild traumatic brain injuries, the ones with a little tiny inconspicuous pixels of blood, without having to call them all the time. But the reason why you have to publish this is because no one wants to take on that litigation and the liability. But by putting these types of papers in literature, then for people who are brave enough to go forward with it, they'll have something to help back them up. So when we don't call neurosurgeons, it's okay. They'll do fine. So we came up with this brain injury guidelines. Dr. Bilal Joseph came up with that terminology, BIG. And this is what we drew up. So we sat in the conference room with a bunch of people, and we made up these numbers out of the air. And we called it big 1, 2, and 3. Neurologic exam, normal, normal, and abnormal, okay? If you're big 1, you're normal, you're not drunk or on drugs, you're not on what we used to call camp, or they campers on Coumadin, aspirin, Motrin, Plavix, okay? You don't have a skull fracture. You do have a subdural or an epidural, but it's less than 4 millimeters. And I'll talk about where I came up with 4 millimeters. Intraparenchymal hemorrhage, just 1. trace of those things. And what you do for them is you observe them, but you don't scan them. Okay, you get a little tiny thing that you saw in the scan, you say, stay here, I'll discharge you in the morning, but you don't call the neurosurgeon and you don't do a repeat scan. So if we did nothing but adopt big one, we've made big progress, okay? So where did we come up with 4 millimeters? Because the data shows if your lesion is smaller than 12 millimeters, it doesn't make a difference. But I chose 4 millimeters because I wanted it to be as tiny as possible, because 8 millimeters is the size of a pea. And 4 millimeters is half the diameter of a pea, which is 1/116th the volume of a pea. Okay? If you had a pea-sized brain in your head, you're not going to operate on these guys. Would you agree with me on that? That we're talking about a tiny BB-sized bleed, that there's not a big deal. And don't worry, this guy's not going to die. Just follow him. Okay, the way we used to 20 years ago, when all we had was a head x-ray. We didn't have head scans. So, can trauma surgeons independently manage traumatic brain injuries without neurosurgical consultation with the implementation of BIG? And what we showed was that you can, it's safe, it's all right. We started publishing it over and over again, blah, blah, blah. And then we did this in Atlanta. Again, I'll tell you, implementation of that was fought with at least 30 or 40 conference room meetings discussing the dangers of this. So it makes a big deal. I know these changes are hard to do. Lots of papers on it saying the same thing, blah, 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 blah. Nothing's really changed. This basically, the bottom line is like the same thing that for minor head injury, we are able to save a lot of money in ICU admissions. Because when I went to Grady, they were admitting every single patient with an intracranial hemorrhage to the ICU. Okay? Every single one of them, and they didn't care how small or how big it was. For the big ones, the severe injuries, you should be doing routines and calling neurosurgeons, okay? But what this does do is save you a lot of money. And if I was able to save the hospital $40,000 a year, that would be a good thing, right? But this did not save $40,000 a year. It didn't even save $400,000 a year. It saved $4.3 million a year. Just the implementation of Big One saved $4 million a year, and I think I should get a small piece of that as my bonus. We reduced a lot of their work. Again, it's a clinical diagnosis. Okay, so pediatrics, it works for kids as well, Dave. We've published it on the kids. Let me talk about coagulation and what's good for that. Nah, let's not. I'll talk about another thing here I want to get to. This shows that hypotension is bad and hypertension is bad. Hypothermia is not good, but it's also... All right, so here's another dogma. MAP pushes. How many people here do MAP pushes in their hospital? You guys know what MAP pushes are? It's mean arterial pressures for spinal cord injury. And there's no evidence for that whatsoever, but it has become another fad that's been going on, and the guidelines have said that they recommend it. So if you look at all the hospitals, everybody has their flavor and their guidelines on how to do it. So some places will do it to a mean arterial pressure of 80, some 85, some 90, some do it for 3 days, some do it for 7 days. They do it for a long time. Ours is 85 for 5 days. And these are the conditions that they're supposed to do it, and this is a hospital guideline that they should do it. So what we found is that we do it about half the time. And why we don't do it, we can't tell. And we have 2 services, ortho spine and neurospine, and we can't tell if it's a fellow that is doing it or one of the attendings. There are some attendings that do it on Wednesdays and don't do it on Fridays, and we just know that they don't, but when they go to the ICU and they're on MAP pushes, it's a nightmare. So we looked at it retrospectively, and what we found is that the change in the AZTrACC score, so A is very bad, E is very normal, and so depending on how bad your spinal cord injury is your AZTrACC score. And we found in 6 months, whether you were on vasopressors or not, the change in your neurologic exam was the same. Most of the people with neurologic deficits improve over time, whether you're on vasopressors or not. It's very expensive. The ICU length of stay is 18 days versus 8 days. Hospital length of stay is also 10 days longer as well. The complication rates are sky high on vasopressors with kidney injuries, ARDS, cardiac arrest, decubitus ulcers, and all these other things as well. So on the mortality, with a capital O, next time I'll change the spell check, the mortality was almost 10 times higher if they were on vasopressors. Now, this is not a prospective randomized study. This is not to show causation. It's an association, and it's hypothesis generating. So, we are starting to do a prospective randomized study out of Portland, Oregon, and it'll probably be a few years to come out, but we'll see whether it makes a difference or not. So if it doesn't help, I don't want to do that voodoo medicine, basically. So vasopressors showed no significant improvement in AZT scores, and there was a lot of increased costs, mortalities, and complications. Outside the box, I'm going to talk to you about one study that we did do. There's this thing called remote ischemic conditioning, where you put a blood pressure cuff either on your arm and leg, and then you let it come up all the way until you have no blood, like a tourniquet. You basically put a tourniquet on your arm and leg for 4 or 5 minutes, and then you release it, and then you get that flushing, and then you do it 4 times, okay? And they found that it reduces inflammation, and it's better for people with MIs and all sorts of things. And, and they're starting to build machines that just basically tourniquet off your arm or leg. And so we wanted to try this, and we did this in a prospective randomized study, and we did it in 40 people in each group, and we did it in very severe head injury. And because we're doing it in very severe head injury, we figured the outcome would not necessarily show an improvement in head injury, but we wanted to at least see if there was a biochemical change in response. And so what we did was we looked at neurosurgical NSEs, a biochemical marker of this. And in our control group, in 6 hours and 24 hours, it goes up, and that's known. All the previous data shows that NSEs and SB100s go up over time. And so we were hoping that there would be a little attenuation of this, but interestingly, in the group that got the remote ischemic conditioning, it had a reversal in the NSE, and the same thing happened in the SB100 as well. So now we're going back to the labs, and we're finding out in animals, when we have percussion head injury models that you can see histologically, if you do remote preconditioning on the leg, that they actually do better as well. So this is something that's very early in the stages, and we hope that will make an impact later on. So there's a lot of ways to manage traumatic brain injury, but I just talked about a few of those. And when we do this, obviously you have to work in coordination with the neurosurgeons in order to make that happen. So the 2 messages that I wanted to leave behind with you was, one, that the brain injury guidelines is well published. You can look those up and try to promote that into your hospital if you can. I think it will really save resources. And 2, that so far there's no evidence to support the mean arterial pressures in people. And with that, I think I am at my time limit, so thank you.